Hey, everybody, welcome back to session 3, which will run for the next hour. This session will focus on ocular melanoma therapies. And to kick the session off, we have our first sponsor presentation from Medicine Pharma. So Medicine are one of our sponsors and responsible for Tebentafusp in Australia and in conjunction with Immunocore globally. So Tebentafusp, what you need to know as a patient. So I must say I didn't quite have all that previous talk available at my disposal when I started this talk, but let's just sort of break it down a little bit in terms of what it is. So maybe in some more consumer-friendly terms. So this is your melanoma cell, and when your melanoma cell is doing its business, what it does normally is that it the internal garbage from that melanoma cell gets displayed on the outside of the melanoma cell with this display mechanism called HLA. And so everyone has different types of HLA, and that's why we need to test. So in the Australian population, it's maybe 30 to 40% of the Anglo-Saxon population have this certain type of HLA which the drug was designed for. So these are like little cups that hold bits of internal garbage. And this type of garbage that it holds is a thing called GP100, which is associated with melanomas, and it gets processed and popped up here. So, and that's sort of part of what every cell does. It displays on its surface, cancer or not cancer, some of the stuff that's going on inside. Then the drug binds to that with very, very tightly, as she mentioned, Tebentafusp, and then it has this binding mechanism, and then it has this other mechanism which activates any immune cell, any T cell, which the T cells are the immune cells that kill things. And so this complex here is known as Tebentafusp. So it binds to this, well, actually lock and key arrangement is what I tell patients. So this is the lock. It's got a key sitting out, and then another lock attaches to it and then activates these T cells. So what do we know? We know that in the pivotal trial, and I remember doing this trial, and we still have patients who are alive who were on this trial from a number of years ago. They got randomized 2-to-1 to Tebentafusp versus other treatments that we used. They were generally immune treatments, or if you couldn't have one of those immune-based treatments, chemo, but only 6% of people got that chemo. So the trial, this is the 3-year update, showed that this is the chance of being alive. So at 0 months, everyone is alive, obviously 100%. And then as time goes on, the chance of being alive decreases, and the median is 50. If you draw a line through here, that's at 21.6 months versus 16.9. So that's half the people. But you could also look at another way. You could say, well, at 12 months, how many people are alive? And 60% versus 72%. And at 24 months, it's 30% versus 45%. So that's a significant improvement compared to these treatments, which we used mainly out of frustration, quite honestly, than anything else that didn't really have much efficacy whatsoever. So that's sort of what we tell patients, and that's why the drug has been approved in Australia, is that this sort of difference in overall survival for the middle median patients is, in cancer terms, very significant and very important. And then what Dr. Carvajal briefly mentioned was, well, how much does the tumor shrink? So you can see the patients who got the Tebentafusp, this is maximum tumor shrinkage. And you can see that a lot of patients didn't have the tumor shrink, and some of them did, but not actually that many, and but certainly more than on the relatively inactive immunotherapy drugs. But this doesn't capture all the benefit of the drug. As you may recall, he had in his picture information which we don't have yet for this trial, which is correlating the survival of the patients with how much their tumor shrunk. So some patients that the tumor shrunk only a little bit lived a very long time. Some patients in whom the tumor grew a little bit also lived a very long time. And maybe that's because measuring the tumor size is a relatively inaccurate way of understanding what's going on inside the tumor. The tumor may be swelling because there's a lot of immune cells infiltrating it and causing it to swell, for example. So there are other ways of assessing the tumor and its growth, such as measuring the tumor DNA in the blood. Now, unfortunately, that test is not routinely available. One day it will be, but until it is, we have to rely on a mix of blood tests and looking at the tumor to see if we can ascertain which patients are benefiting. But one thing is for sure is that we don't automatically turn off the Tebentafusp when someone's tumor has grown 10% or 15%. In particular in this area here where we really don't know what's happening. And the other, oops, why are the slides jumping? The other aspect of this is that this is not, this is called progression-free survival. This is not overall survival. This is the tumor growing. And you can see that for reasons, again, we don't completely understand, the difference between the two, if you look at the 50% here, is not that great. So the tumors seem to enlarge to some extent, but maybe that enlargement at the same rate as they do with the other drugs. But maybe in the other drugs, that enlargement is due to the tumor growing, but with Tebentafusp, maybe it's due to some swelling or something. And these things we don't really have insight into, but we do know that Tebentafusp does work quite well. Now, what else do we need to know about Tebentafusp? We need to know about the side effects. So this is a picture of the side. This is a picture of the side effects with time, and you can see here that the side effects differ as time goes on. These are months: 0 to 3, 3 to 6, 6 to 9. And what we have to do with Tebentafusp is we have to admit the patients to hospital every week for the first 3 doses, if not 4, to make sure they don't have any untoward reactions. And what are those untoward reactions? You can see them here. So the rash, well, that can be troublesome, and most patients seem to get a rash. That doesn't require you coming into hospital. You can have a rash as an outpatient. The fevers, in combined with this green one, which is a low blood pressure, that can be a bit more dangerous. And so if you have very low blood pressure, you can obviously faint. So we can't have people fainting when they're at home. So that's the reason why we have to admit patients to hospital. And so patients ask me, well, why am I getting these things? So the reason is that, if you remember on my first slide, that piece of internal garbage that gets put up on the melanoma cell, the GP100, is also in normal skin because it's part of the melanin machinery, if you like, and that is also in your normal skin. So the drug sticks to the tumor. It also sticks to the skin. So that's why you get rash. And then that's also why the blood pressure falls, because the skin dilates and a lot of the fluid and the immune chemicals which are circulating because of the activation of the immune system cause the skin to dilate, and also your blood vessels internally to dilate, your blood pressure falls. So until we sort of saturate your skin with the drug, which takes about a month, and your skin gets used to it, you'll keep getting the rash and your blood pressure would keep falling. So we do sensible things, and we'll talk about those things, like we stop taking blood pressure tablets, we fill the patients up with some intravenous fluid. And you can see, though, that when we get out here 3 to 6 months, the side effects are dramatically lessened. And in fact, this drug inherently, after those first 3 or 4 doses, can be given almost in a community health center, and certainly in a rural cancer center, because there's no significant risk of material side effects. So with just those first 3 to 4 doses are the ones which are more difficult to manage. So these are the questions which you need to ask if you're going to start using Tebentafusp. Are you the right patient in the right location with the right support? So we talked about, have you been tested for HLA-A201? So if you're a uveal melanoma patient in Australia, this test to check your immune system is available on the Medicare system, so it shouldn't cost you anything. And if you have metastatic uveal melanoma, that's the first blood test you need to have done. So, because you need to know if you are suitable for that drug. So, and that's a blood test that takes about a week to come back. It's done in most major capital cities, so it can't be done in the local lab, but it doesn't take too long because they use the same type of blood test for a variety of other types of conditions. And so it's run fairly routinely. And so you need to know if you had that blood test. You need to ask the question, are there any clinical trials available? We talked about the importance of clinical trials in uveal melanoma. And you need to ask that question because sometimes, I don't know if it's going to be next week, next month, or next year, there may be trials where there may be other drugs that might add to the effect of Tebentafusp, and you need to ask that question to see if you're suitable for any of those. If there are any available either around the corner at the other hospital or in the major city or in another city. You need to understand your prognosis because a lot of people starting on a drug will need to know its impact. And then you need to ask the question is, can they send you to a center nearby, which is maybe more convenient for you, but certainly one that has experience with the drug. So those first 3 administrations, which may involve being monitored every hour or every couple of hours, and potentially the need for intensive care units in the vicinity, need to be considered. So that needs to be carefully thought through. And then need to understand questions about whether you have access for nursing. Is there ICU nearby if you get sick? I must say that's very rare, but that's why we're very careful. And is there supportive care services around? So certainly pharmacists are essential. Dermatologists can be important if you get a bad rash, and giving advice about how to deal with that rash, and obviously radiology. So these are some of the side effects from Tebentafusp that are sort of graphically illustrated. This CRS is a catch-all phrase for that low blood pressure with fevers due to all the immune drugs circulating. This is the time since the Tebentafusp dosed. So you can see here that the patients, at least in my hospital, tend to get their Tebentafusp in the sort of, usually they're getting it in about 2 or 3 in the afternoon, which means that this low blood pressure combined with a fever tends to occur about 11 o'clock at night, which is when my phone usually rings, and we talk it through. Usually it's not too bad, and the patients get some Panadol anti-inflammatories and maybe some intravenous fluids. And then we keep a very close eye on them in the hospital bed with very attentive nursing and medical staff. And then they tend to get the rash the next day, and we tend to work through that with various other things, although that can be also difficult, especially with the itch. So the itch can be troublesome. And there can be some liver function, partly due to the immune drugs circulating can irritate the liver, but we usually keep an eye on that. So that's sort of what happens, and especially scary in the first 3 doses. And we do the same thing 3 times, and then after that, it tends to get better. The here are some skin issues you can see. These are some of my patients. You can see the types of skin rashes that they've had and the pictures of those. It can be itchy, it can be red, it can be swelling. We had one patient who had to stand up next to her hospital bed because every time she sat down, when her skin touched the bed, she felt that it was painful, and that unfortunately persisted for a couple of hours before it settled down. But it can be very uncomfortable for patients, but fortunately is transient, and most of them are mild or moderate and do resolve with some topical steroids and a few things like that. Here's some more skin reactions, and so this unfortunate lady was also somewhat uncomfortable with that rash, and we use some antihistamines and some topical steroids, and sometimes we try even a drug called a aprepitant, which may help for the itch, and we've published on this. But just so you understand what some of these patients are putting up with in the first month of treatment. So the questions you need to ask as a patient, though, are, in those first infusions, have you stopped your blood pressure medications? Because you don't want to be taking 2 things to make your blood pressure go down. Did you receive some intravenous fluid to help keep your blood pressure up? You need to take some Panadol or Nurofen or something before the next dose, because the first time you had such a difficult time. Has the hospital arranged to give you the drug and move you from the outpatient area to the hospital bed in an efficient manner? We don't want you being wheeled across a road whilst your blood pressure is low. And you booked in to start early in the day. So arguably most of the patients, I would like them to start their Tebentafusp and have it done by 10 a.m. so that if they do get unwell, it's still during the working hours of the day. But sometimes, given the practicalities of the cancer centre, that's difficult to arrange. But if you have a choice, it's always better to get it over and done early. And then if you do get unwell, there's more people around. Make sure that there's nursing and medical staff around. And we have a very tight protocol in my hospital to make sure that everyone is informed about what's going on, ranging from the junior nurses all the way through to the senior nurses, as well as all the medical staff. People check on you, and you need to have probably a cannula in to make sure if you need to get intravenous fluids, you got them, and then sometimes a decision about the 4th dose. So the questions that we need to then answer are, as a community, I think, is, do we need to give this in major centres, and then send patients back to their local hospitals for the smaller doses? There certainly will be larger rural hospitals that will take on this responsibility. We don't actually know who's taking on that responsibility yet because the drug's just gone on the PBS. We need to talk about rescanning the patients, about how long do we wait, and how to interpret those scans. And rest assured that you can take a break. A lot of people say, do I have to take it every week? I want to go on holiday. Usually that's fine. And it's certainly, probably once you've established on the drug, you can certainly take a break for a week or two, probably, for special circumstances. So so they're the sort of the main issues that we're grappling with as a community in terms of the Tebentafusp. And then we have to think about what do you do when you stop? We have to make a very careful decision about stopping the Tebentafusp, in terms of understanding whether the disease is actually growing through the Tebentafusp, and we've talked about some of those issues. So, and then once your decision has been made to stop and you're sure that's the right decision, you have to look at what are the alternatives. Can you access them? Is the patient and the doctor aware of the consequences of stopping the Tebentafusp? Do you have all the support you need around that? Do you need even the palliative care service? And do we need referral to another centre for high volume, for trials? So again, we have to make sure it's the right decision with the right support and you have the right plan. So that's my time. The couple of questions have come up, which I'll quickly just answer. There are clinical trials usually in most major capital cities for uveal melanoma, metastatic uveal melanoma, and the blood test, the HLA blood test, is it can be taken in a local lab. I can't speak for every local lab. Some of them may look at that blood form, which is called an immunogenetics blood form, and say that they don't know what it is and they don't know how to deal with it. But if you go to a major blood taking facility, they will probably be familiar with it because, as I said, the form is used for a number of conditions. It's just the actual type of test varies. So a lot of people who have various types of autoimmune conditions that need that blood test taken. So I think in a larger blood taking center, they'll be familiar with it. So thank you very much for your attention. I will now hand over, although I'm slightly over time, apologies, Dr. Carlino, to Associate Professor Matt Carlino, who may be well known to many of you. Dr. Carlino is a medical oncologist at Westmead Blacktown Hospitals and an associate professor at the University of Sydney and a faculty member of the Melanoma Institute of Australia. He did a PhD exploring the predicted mechanisms of response and resistance to various types of targeted therapy in cutaneous melanoma and does a lot of translational research investigating the response and mechanisms of resistance to both targeted therapy and immunotherapy. He has a clinical interest in melanoma, non-melanoma skin cancer, as well as uveal melanoma. He's one of Australia's stars in the uveal melanoma space. So he's done some amazing work, and I'm very excited to hear him update us about that work.
Okay, so hopefully my presentation supplements some of the stuff Anthony's introduced, but also some of the work Darren described about the IDEA compounds. So I'm going to talk about targeting GNAQ and GNA11, and I'm going to share some lab data, which I'll talk people through slowly, but also some clinical data and jump and change. But hopefully I'll keep it understandable. So I've been involved in a drug development with a number of companies, but particularly two companies, IDEA and Novartis, who have made drugs that I'm going to talk about a bit today. So the first thing I'm going to talk about is stuff that we get in laboratory medicine, a term we call oncogene addiction, and I'll explain what that is. And then I'm going to talk about really two drugs which are really specific to uveal melanoma, which are in clinical trial at the moment. So a few people have talked about GNAQ and GNA11 mutations, and almost all uveal melanomas have a mutation in one of these genes, or mutations in other proteins which are close by. And so when you have a mutation that is very common in a given cancer, it's an attractive target because you can say by targeting one protein, you have the potential to treat a large majority of those patients. It's a pretty complicated signaling molecule. So Darren showed a picture where protein kinase C was downstream of GNAQ and 11, but there are lots of things downstream. And this is a more complicated picture on purpose to say that signaling inside cancers is often complicated, and to be honest, we don't often understand it completely. So what's this term oncogene addiction? So think of oncogene addiction as a problem with a cancer that is so important to the cancer that without it, it can't live. And the question we've got is GNAQ and GNA11 an example of this? And there are lots of examples of this in cancer. So the one to patients with cutaneous melanoma, they talk about a BRAF mutation. And if you remove that BRAF mutation, that cancer cell cannot survive. We have a similar thing in a subset of lung cancer and other cancers. And that makes a very attractive target. So BRAF's a great target in melanoma that has a BRAF mutation. But what about GNAQ and 11? Is that a good target? So this is some data from a laboratory, not one of ours, but a study published over 10 years ago. And what this shows is the proteins expressed in the cell. So GNAQ is along the top, and on the left is GNAQ being expressed. That's the black bar. And then the scientist lowered the levels of GNAQ in that cell, and that's the lighter bar. So almost got rid of it. Now, if you get a cancer cell, these are skin cancer cells, skin melanomas, and you lower GNAQ, it does absolutely nothing. So all the cells are viable, 100% viable, and that makes sense. The vast majority of skin melanomas don't need GNAQ. But if you do the same thing in cells that are from uveal melanoma, you can see those cells die. What about if you do that with a drug? So this is a compound that directly inhibits GNAQ and GNA11. And this curve here shows those cells dying, so percent cells that are viable, cells that are alive, and all those coloured lines are different uveal melanoma cells. And as you increase the dose of this compound, they die. The black one is a skin melanoma cell line, and because it's not dependent on GNAQ, it doesn't die. Now, looking at that, you go, this drug looks great, let's give it to people. The problem with this compound is it causes bleeding and profoundly low blood pressure. So it's a drug that works well in a test tube, but not so good if you give it to an animal. What about if you block downstream of GNAQ and 11? We go, look, it's hard to target that. Let's go downstream. And so this here is a bunch of cells. The ones in red are the uveal ones, and the others are other types of melanoma. And IC50, the lower the number is, the more that drug works in that cancer cell. So you want low bars. And you can see this thing called a MEK inhibitor works just as well in red, perhaps better for the uveal ones than it does for the skin ones. So a very sensible decision to say, let's give MEK inhibitors to people with uveal melanomas. And I'm not sure if covered earlier, but that was tried in clinical trials and unfortunately didn't work very well. It was hoped based on all this lab data that these drugs would work, but they didn't. The next thing, and this is where we're getting to the darasertinib story, is protein kinase C. If you give a protein kinase C inhibitor, to the uveal melanoma cell lines, they're dying. If you give it to the skin melanoma cell lines, they're not. So is this an attractive drug? And about, I want to say 5 years, but probably longer now, the first of these protein kinase C inhibitors was tried. And there was a lot of interest in this drug called AEBO71, but it's fair to say it was a little bit disappointing. You've seen these waterfall plots on other presentations, and down means the cancer's shrinking, and up means the cancer's growing. And unfortunately, for the majority of patients on this drug, the cancers grew, not shrunk. The other thing was this drug had a lot of side effects, and really it was the side effects that made it an unattractive drug. Maybe we couldn't give patients enough of the drug because it was so toxic. But this was proof of concept that targeting this thing called protein kinase C was reasonable in patients with uveal melanoma. We then moved on to the next of these drugs, and this is daracertinib, but it's had a few names. It was first called IDE196, and then LXX196. And I think this is a good example of really perseverance. So our first trial with this drug, we gave it alone, and you can see there was some patients that had shrinkage. So these are patients on the trial we ran probably 4 or 5 years ago now, where we had some patients who had shrinkage when we gave the drug once a day, and we had some patients get shrinkage when we gave the drug twice a day. But it's fair to say, once again, not as good as we'd hoped. The main side effect when we gave the drug by itself was low blood pressure and syncope. Syncope is fainting. And then we tried combining it with other things. This was before IDEA bought the drug, and really at this point it was unclear to the community, was this drug good enough to really become a standard treatment? And that's when IDEA got involved, and to their credit, they took a drug that had a little bit of activity, thought about it, invested time, energy, and money, and decided to combine it with crizotinib, as Darren explained. And so this is the data from that trial that was presented at a European meeting last year. And now when you think about this waterfall plot, there's many more patients where their tumour's shrinking than when their tumour's growing. So clearly this looks more active than those previous curves. The vast majority of patients had benefit where the tumour's shrinking. As oncologists, we often have a cutoff of 30%. So when people say the response rate is 30%, that means patients that had a shrinkage of greater than 30%. But there's a bunch of other patients who have some minor shrinkage. The drug looks perhaps even better when we give it to patients who haven't had lots of other treatments. So when we look at the patients on that study who this was the first treatment they ever got, the vast majority of them had shrinkage. And if you look at the patients whose melanoma is only in their liver, the shrinkage is even better. Now, side effects. It's fair to say this combination of drugs takes a little bit of time for the patients and the doctors to get on top of the side effects. The main side effects are nausea, diarrhea, vomiting, blood pressure, and fluid retention. And it's a very individualized approach. So different to Tebentafusp, very different, but in the same way, it takes the doctor and the patient and the nurses a little bit of time to individualize how to control those side effects. So if you are a patient who's had this drug or will have it in the future, communication is really important to work out the best way to control those side effects for you, because it's fair to say that each patient sort of has a different way, and what works for one patient may not work for another. And I often find it takes about a month or a few weeks at least to get the best way to control side effects for an individual. The drug works, and we're trying to work out how long it works for. And certainly Anthony and I both have patients who have been on this drug for over a year. Now that's led to the clinical trial that Darren mentioned. This is a phase 2/3 trial where patients either get the combination or immunotherapy largely. Now, the trial looks a bit complicated because we're still trying to work out the right dose. But for patients who are going on this trial now, they either get the tablets at 1 of 2 doses or immunotherapy, typically ipi/nivo. In a few, hopefully not too distant future, in a few months or so, we'll work out what the best dose is. And then the trial simplifies, as you can see down the bottom, where patients only get 1 dose of tablets. And we're not far off. This trial's probably been open for about 3 months so far, open in Australia and the US, and will soon be open in Europe. So what about another way of targeting GNAQ and 11? So I mentioned to you that we had a drug that could target it, but we couldn't give it to people because it had so many side effects. So what was designed by the smart doctors in Novartis was a drug that is what we call double targeted. So this drug is an antibody that binds to the outside of the melanoma cell. And there's lots of drugs in cancer that do this. Most of them inject chemotherapy into the cancer cell. But this is different. Instead of this antibody injecting chemotherapy into the cancer cell, it actually injects that GNAQ/11 inhibitor. So it's almost what we term a double targeted drug. So we get the drug to the cancer cell, but it doesn't go anywhere else. This drug's in what we call phase 1 trials, so it's very early on in its development. And about, I think, a bit over 50 patients around the world have been treated with this drug. And we're increasing the dose to work out what the right dose is. And last year, I presented the data from this trial of these first 50-odd patients. The first thing to say that was really surprising when we're giving this drug to patients, or perhaps not surprising, is it has minimal side effects. And that's because of this double targeted approach. Really, we had no severe side effects. So grade 3 and 4 is severe. And we had some non-specific side effects like fatigue, a little bit of a high calcium, but very minimal side effects. Grade 1 is minor, grade 3 and 4 are the severe ones. So that was really pleasing to see that the double targeted approach worked as predicted. No patients had to stop drug because of any side effect, which was great. Whenever we're developing a new drug, the patients on these trials get lots of blood tests to try to let us learn about the drug. So this is the concentration of the drug in the patient's blood. This is more important. So this is the concentration up the top of the drug that is active, the drug that can fight the cancer on the top. And the dotted lines is the drug that's free, the drug that would cause side effects. And you can see the difference between the drug that hurts cancer and the drug that causes side effects is 1,000 times higher. So 1 nanomole versus 1,000, really telling us that this approach is an excellent way to minimize the risk of side effects, but still get enough drug to the cancer. And now we show you that waterfall plot again. Down is good. We want the cancer shrinking, and a significant proportion of patients that have shrinkage. Whenever we start a new drug trial, we start at a low dose because we don't want to expose patients to a potentially toxic drug at a high dose. And you can see as we've increased the drug dose, it looks like the drug's getting better. So the patients who started early at a low dose, this is probably a dose that's not good enough. Not many had shrinkage. If you look at the patients who had the higher dose, most of them had shrinkage. And we're now just going on with this trial to work out other ways of trying to optimize the best way to give the dose. And there's a significant proportion of patients who continue on this drug, which is fair to say really early in its development. So what I'm going to conclude to say is that I think GNAQ and 11 are effective and appropriate targets. The phase 3 trial is started, and that means hopefully we're not too long away from having a drug, which can be available if the trial reads out as positive, which we hope. We can inhibit it directly, but we need a fancy strategy, and that's that antibody drug conjugate I showed you. And that's it. And hopefully I'm on time, Anthony.
Yes, thank you very much, Matt. That was very informative. We won't just do questions just yet because we have to turn to Anne Goulter. So Anne's presentation is going to be initially by video. And then I think she'll be online to answer questions. So I'll just quickly turn to the video just to briefly orientate you all. Anne is a New Zealand patient who began with the diagnosis of right choroidal melanoma in April 2023 and then had an enucleation. And she was well with monitoring until an MRI in November 2023 revealed some liver metastases, and was trying to get on a clinical trial in Auckland, but then sought access to Tebentafusp actually in Australia. So she's going to talk about her journey in this video.
Kia ora, and thank you. So this is my view as a Kiwi with the option of a trial and being on tabby. So January this year, having been diagnosed in November, I found an article in the New Zealand Herald, 1,000 Kiwis die every year who would have survived had they actually been in Australia. It really doesn't give us Kiwis dealing with cancer a lot of confidence. And I think that's a really important point. Background and diagnosis. So Easter last year, I suddenly experienced black lace in one eye, ended up at our Green Lane accident and emergency eye clinic. They're a bit startled. I got called back for a second appointment, and on the 19th of April got diagnosed with an ocular melanoma. Due to the size of the actual tumour, the only option I was given was a removal of the eye, and that happened on the 27th. After the eye removal, you can see I've rocked some bandages there on the left-hand side. Went round with just an eye stitch shut in the middle of that photo. And after the actual stitches got removed, I did at times rock an eye patch. Found that rather annoying. Kind of cuts across the eyebrow and it flicks up. It does stop you scaring small children, but it's not that easy to wear. And so generally I just rocked the open, empty eye, and it was good. Definitely scared a few people, mainly small children, but no, it was fine. And that's a picture of my husband's 70th, and yeah, I'm rocking the empty eye look. Prosthetic eye happened in October, which was really great to feel whole, feeling really, really good, felt really, really good. And then after some scans, November 16th, got diagnosed with liver mets, and that was a huge shock. I was not expecting it to be so quick. I knew I was very high risk, or moderate to high risk, but did think I would get longer than 5 months. We did look at a possible trial, which we investigated December, January, which I'll talk about in a moment, but January 30th, I got accepted on the Australian-New Zealand Compassionate Access Program for tabby. The trial that we became aware of through Catherine Han was the PRAM trial, although at the time it was given to me as the Florence trial. So I did actually go on the end of January when we did speak to Prof. I did talk about the Florence trial, but it was actually the PRAM trial. Had all the right bloods, but unfortunately they changed the dosage, and because of that, everything had to get put back. And so after 8 weeks of kind of waiting in no man's land, it wasn't going to happen. So we therefore had to look at other options. So that's what happened there. And then basically what we're looking at here is, what does New Zealand offer somebody in my situation? So an ocular melanoma, now with liver mets. So 2 options, Keytruda, again, that's not funded, and that's 60,000. And then we have CERT, again, not funded, and in New Zealand, that's 40,000. So they're the only 2 options that were actually available to me January 2024. Thankfully, through an email sent to the New Zealand and Australian Facebook page, I actually found out about the Compassionate Access Program, and in discussion with Catherine Han, I ended up with a referral to Prof Anthony Joshua at St Vincent's Hospital in Sydney. Got in by about 24 hours and got accepted onto that Compassionate Access Program, and had my first infusion on the 19th of February. Tabby, infusion 1 and 3. Yeah, I got the serious shakes, then the incredible high temperature, getting to about 40 degrees. Easily sorted with fluids and Panadol. Nothing more was required. Skin was very, very red. My skin felt like I had been rolled through pink bats. So Kiwis, most you don't know what pink bats are. So the fiberglass that gets placed in roofings to keep the temperature inside a house. So it felt like there were small glass shards in every cell on my skin. Couldn't touch my back and shoulders to start off with, but it was itchy. Everything itched, and the skin was very, very red and inflamed. And the first, from about 7 p.m. to about 1 o'clock, I would itch the top half, and then in the early hours of the morning to about 6 a.m. I could lie on my back and I just scratched thighs and shins and feet. And yeah, it was a very long night, but you know, that's just what happens with Tabby. Did get some sore joints as well. There was some reaction on 4 and 5, but we had some steroids. Started off with a dose, and then halved it, and then really from infusion 9 onwards, no steroids, no reaction, and it's been quite easy. The only thing I have to say now is I know my eyebrows are going white, my eyelashes are going white, got a bit more grey than I've ever had in my life before. Other than that, dealing with life pretty normally, which is really, really what you want. Photos here of some of my hands and feet. First couple of weeks, my hands went red, as you can see on that left-hand side of the hand photo, and then I just peeled. I lost a lot of skin, had a bit of a blister there on the right-hand side. By infusion 3 and 4, my feet went that red color, and then I totally peeled, heels and soles of the feet included. And that really kind of took a long time for all that skin to come off. A little bit gross at times, but sitting here now, hands and feet are all fine. Skin's looking nice and fresh. So my present new normal is Sundays I fly to St. Vincent and stay in the patient accommodation. Amazing option. Monday I have an infusion at Naloon. Monday late afternoon I fly home. Supposed to arrive in before 12, but the flight's always delayed. We get in about 2 a.m. in the morning. I work Tuesday to Friday. I'm a secondary school maths teacher and head of department. Saturday and Sunday spend with family and friends, and then repeat. Trying to pick up some gym work and a bit of exercise. And that's my new normal. And it's working. Game changers. That mobility sticker that I got through a New Zealand GP, amazing. Our vision is different now. You know, they said it would come back. Mine hasn't come back. So I'm about 50 centimeters out, right, left, forward, and back. I can park if there are 2 car parks or 3 car parks free. I cannot park if there's a car on the right and a car on the left. I just can't tell the distance. And so I'm very, very nervous to park, you know, at peak at the gym, you know, at a supermarket. I have driven around before, and after 15 minutes left the supermarket and gone home without any purchases. So by getting a mobility card and giving me the large car parks, I have the freedom to shop, to go to the gym, to be me, you know, to be independent. And that to me was a game changer. And the second game changer I've put down here is that Australian and New Zealand Facebook page, and having Lisanne there as the Ocular melanoma nurse. You know, she is part of the reason I got onto Tabby, but that support you also get, because this is one lonely journey. It really is. And to have somebody who understands and is there to support is, again, it's just wonderful. It just makes such a huge difference. To me, I just kind of wonder if there's something missing from our personal warrant of fitness. You know, I do the smear test, I've done the mammograms, I get my teeth cleaned, I do the 6 monthly dental checks and the bowel cancer checks, and my skin gets checked yearly for skin cancers, and my eyesight hasn't changed. So I haven't done any eye tests, or I didn't do any eye tests. Had I had an issue with my eyes, had I had a change of vision, I would have had an eye test 2 years ago, 3 years ago, anytime, and they would have picked up that there was a tumor there. But because I didn't have anything changing, I didn't have an eye check. And I just think, had there been some communication about the importance of checking our eyes, I might not be on this journey here. It could have been caught earlier. And had it been caught earlier, I wouldn't be here today in front of you guys. These are the amazing people who've helped me along the way. You know, it's to get to here, you know, from the initial diagnosis to the patient support, to surgeons, to my New Zealand oncologist, to Kathleen, who has given me a normal look with 2 eyes now, to Prof Joshua, to Lisanne, and you know, they've all played a part, and it's really, really important. And one group of people I'd really also like to add in here are all the amazing nurses at Naloon. You know, you come in every week, they treat you with respect, it's positive, and it's been a very important part of that journey is meeting with those people. So the only thing I could add here, which I haven't actually put in, is where I'm at now. So unfortunately, Tabby hasn't shrunk the tumors, and so they are still growing, but I feel really good, and I'm living an incredibly normal life, even though I'm traveling to Australia every week. And at this stage, we are looking at, or through advice through Catherine and Prof Joshua, we're looking at maintaining Tabby and looking at CERT. And hopefully get the tumours sorted, and from there, look at any possible trials that are coming up in the future. I'm not giving up. I've got too much to lose. And yeah, it's what gets you through are the people around you and the support. And that's what keeps me going. And thank you for listening. And I wish everyone the best.
And welcome to the session live. I'm not sure if you're in New Zealand or where you are, but welcome. And also, thank you, Matt, for joining us on the Q&A as well. Firstly, I just want to say thank you to everyone who's donated. So we've certainly had a couple of donations and through the web link and QR code. Certainly keep that up. That's great. And certainly the money will be used to advance research and patient support facilities for patients with uveal melanoma. We'll just bounce around a few questions just till 12:15. But and do you want to just start by maybe just giving us all an update? That was very insightful and heartfelt video. How are you going?
I still feel really, really good. I mean, I've just had 2 weeks traveling. I've been to the States to visit my son, and I've managed to get through that. And I do still feel good. And that's the frustrating thing, that the drug's not working, but I feel good. And it's now having to look at where to now, you know, what is the best option. So that's where I'm at. You know, is it CERT? Is it waiting for a trial? What is the best option? And unfortunately, there's no crystal ball that's going to, you know, tell us what is the best option. So that's where we're at this stage. I'm back. I'm actually in LAX airport as we're speaking. I'll be back in Sydney on Sunday. I have my next infusion Monday, and I fly home Monday night. And that's life, and it's awesome. I mean, it's also awesome that through Catherine and the drug company, we are looking at getting Tabby into New Zealand, which I think is also awesome for me, but for anybody else who ends up on this journey, or for any of the immunologies that require the albumin to be added to it. So I think that's really, really important. So, yeah.
Great. So there's actually, and there's a couple of questions that whether people, if we have your permission to share your journey through some of the through your video. I think people took a couple of screenshots, whether they could use your journey as a advocacy piece, I think, for other patients and also for screening. So that's very generous of you. Thank you.
Absolutely.
Great, thanks. And Matt, then Matt, what are your feelings about where we're going with DYP, which was the...
So it is a very challenging drug to develop. It clearly has activity and clearly deserves to be, you know, taken further for patients. We're still working on getting the dose right, and there's a few little things to work out. Should it be given 2 weekly or weekly? But it's fair to say it's been slower than patients particularly, but also doctors have liked. And there are discussions about which drug company will be taking the drug forward. But I'm confident that the drug works enough to justify someone, whoever it is in the pharmaceutical industry, developing this. And I think darasertinib is probably a good analogy. That drug was initially owned by Novartis and developed by Novartis scientists. And IDEAYA really, to their credit, took on a drug that may not have got to where it is now. And so hopefully I'm hoping the same thing will happen with DYP. But it's too good a drug not to go further, in my mind.
Great. So I think we're sort of wrapping up there for the end of this session. So thank you all very much for your time, and thank you very much for dialing in from LAX. That's a painful location to be in at the best of times. So let alone listening to yourself on a video. Thank you everyone for attending.